Hello and welcome to our review of the lupus literature for March. We're going to be recording these podcasts for you every month, so you'll always be able to keep up to date on the latest literature and expert opinions. I'm Ed Vital, chair of the Lupus Forum. I'm at the University of Leeds in the UK, and I'm joined today by Professor Chris Edwards, who's a consultant rheumatologist and honorary chair of clinical rheumatology at University Hospital, Southampton, UK. Welcome, Chris.
Hi, Ed.
So today we're looking at the key March publications that are covered on the Lupus Forum. We've got 3 papers selected, and the first one is one that I took a look through, which is by Katsumata et al., and that's on behalf of the Asia Pacific Lupus Group. It's published in Annals of Rheumatic Diseases. So this group have got a large multinational cohort of patients across a range of Asia-Pacific countries with varying types of healthcare system, but quite a lot of bad lupus in that region. And they've published a few times on outcomes from these papers, especially about things like the use of steroids and low disease activity in LLDAS. So this paper is continuing that theme, and I think it's quite an interesting take on the subject. It's about the risk of flare and damage accrual after tapering glucocorticoids, but this is in serologically active, clinically quiescent patients specifically. So this SACQ concept has been around for quite a long time, I think originally defined by Daphne Gladman, based on the observation that you get some patients who have high double-stranded DNA or low complement, but clinically seem to be doing very well. So what should you do with those patients? So the initial observation that was made in the first studies on these people was that actually in the long term, these patients' outcomes in terms of damage were quite similar to people who were serologically quiescent and clinically quiescent. And so in other words, you shouldn't just treat the serology, you should just monitor these people. But things have changed a bit. So in the original studies, obviously the therapeutic landscape a few decades ago was a bit different, and they were actually excluding patients on steroids from those studies. But now we have a really big interest in steroids because we know they're such an important predictor of long-term outcomes. And actually, there are a lot of, when you look at a lot of the lupus research now, there's this general sort of melding of the concepts of disease activity and steroids. So the LLDAS outcome measure requires you to have a low SLEDAI and low steroids, otherwise you're not meeting it. Or there was, for example, a thing called the SLEDAI 2K GC, which is like the SLEDAI 2K, but you also get some points for your steroid dose. That might make your SLEDAI higher or lower. So the specific question here was how to manage patients who are serologically active, clinically quiescent in terms of their steroid use. So patients here had a SLEDAI 2K of 2 or 4 that was entirely due to their DNA and complement points. They only need it on 1 visit for this, doesn't have to be sustained, and they had to be on prednisolone between 0 and 7.5. They could be on antimalarials and immunosuppressants, and they had to have at least 2 years of follow-up. And these patients were observed from that visit to look for a primary outcome of flares, which could be severe or moderate, and secondary outcome of damage, and a particular sub-analysis for glucocorticoid-associated damage. And all of this stuff was analyzed in a multivariable time to event model that essentially tried to say for each 1 milligram decrease in prednisolone, what effects does that have on your time to flare or your time to damage after adjusting for a load of other disease characteristics like antimalarials, disease duration, gender, so on. Main results, about half of patients flared, about 1/7 had a severe flare, about 3/4 of the flares occurred on people without a GC taper, and overall GC tapering was not significantly associated with flares on its own. As you might expect, antimalarials and immunosuppressants associated with less risk of flares, and also as you might expect, people with worse SLEDAIs and high GC doses tended to get more flares overall. So tapering GCs wasn't associated with flares, was it associated with damage? So about 10% of patients had an increase in damage, And tapering prednisolone was associated with a reduced risk of damage, including some of those steroid-associated damage points like osteoporosis or diabetes. And the summary was overall result was that tapering prednisolone by about 1 milligram reduced the risk of damage by about 4% without increasing the risk of flare. So in conclusion, for clinical practice, this would sort of suggest tapering steroids should be attempted. And it's probably better if you're on antimalarials and immunosuppressants and easier to do. And then the other thing I noticed was that within the that range from 5 to 7.5 of prednisolone did not appear to be completely safe. And actually tapering GCs in that range of 5 to 7.5 will reduce long-term damage, and therefore there is some preventable steroid toxicity going on in that dose range. So those were my thoughts on that. What did you think, Chris?
Yeah, I was trying to link it to clinically what we do, and I suppose for many of us, we've spent the last few decades trying to reduce our steroid use, and that's been in the doses of IV methylprednisolone we use, and going to use other drugs, other immunosuppressants earlier, mycophenolate earlier, other but now biological therapies earlier. But there's a group of people when you get really low that I still wonder about, and this has given me a bit more confidence that maybe I should be reducing it. I'll give you the example. It's those people who've had, this may sound a bit dramatic, but organ or life-threatening disease.
Yeah.
There's still women who are premenopausal, so you think they're sort of the estrogen type drive for their disease is still there. And in those people, although I try to reduce really low, when I get to 3 milligrams, I tend to stop at that level. And maybe that's the bit you made about the 5 to 7.5 milligrams range supports that a bit. Reduce that bit, get it really low, and then when they become, 5 years postmenopausally, the disease is becoming quite, at that point, that's when I start to think, can I really take away all the steroids at the end? But maybe this sort of data says I should be doing it even those last few milligrams, but I just don't want to get into this stop, start when the disease is still, I don't know, what do you?
Yeah, I agree. And I mean, one thing is, of course, is avoiding the steroids becoming long-term in the first place, isn't it? Yep. If I did in an ideal world, of course, the steroids are just a short-term induction treatment and you don't have people on them long-term. But I know that's easy for me to say, but it's not in the real world. People are on steroids long-term. I definitely think, there has been, when LLDAS was first defined and when the EULAR criteria, the previous version came allowed, the steroid target was 7.5. And now everyone's saying 5. And I think this supports that. Yeah. So being down in the lower 5 or less. I think in these Asia Pacific cohorts, one of the previous analyses did suggest that cutting steroids would increase the risk of flare a bit. But I noticed that quite a lot of patients in that study weren't on immunosuppressants or biologics. So maybe
so you have to take this account. Because the one thing about this cohort, I think you mentioned it already, is there will be people with very active disease from Southeast Asian countries that will have very bad disease. So if you can reduce in this population, you're likely to be able to reduce in other populations as well, I think.
And then, of course, the other thing is, like you say, when you've had it for many years, when you get down below 5, you've got a load of sort of hormonal effects and things that are going on that's different from just disease activity and flares that you're thinking about, isn't it?
Yeah, absolutely.
They also made an interesting point in this paper, actually, that I didn't know, that they did a patient survey of people on low-dose steroids who generally said, we don't want to stop it, which I thought was interesting. Anyway.
And maybe that's the thing we should keep in mind as well. So the move is, we all want less. We'd all like to stop. But you see this a little bit in some of the rheumatoid literature. You think, well, how far do you push it? And some people do they just feel better and have a better quality of life with a little bit of steroid? And we've pushed and pushed and pushed and pushed, and almost inevitably, when humans move in one direction, you come a point where you overshoot, and it may be that below 7.5, yes, but that last few minutes maybe we have to be a bit careful with that. Maybe
it's a more complicated equation, isn't it? I think is the way of it. Yeah. Should we go on to the next one?
Yeah. So this was one I took a look at. Well, if you wanted a review of TYK2 inhibitors, written by some really smart people in a nice format with some nice figures and pictures. This is a really good place to start. And it's a review that includes lupus, of course, but it also has some data around psoriasis and psoriatic arthritis. And it has a little bit of a think about what TYK2 is. So, of course, there are 4 JAKs, of which TYK2 is always confusingly called tyrosine kinase 2 rather than being called JAK4, but I guess it helps to differentiate as something slightly different. And it's interesting now because there are a number of inhibitors of TYK2 that are being developed and are in trials, some of them in earlier phase trials, some of them phase 2, some 3. And deucravacitinib has been licensed for use in psoriasis, certainly in some countries anyway. So this is getting to the point where it's in phase 3 and into the clinic in various disease areas. They review the background of TYK2, what it is, why it might be interesting that TYK2 is involved in the signaling of things that might be of interest in lupus, such as interferons, such as IL-12/23. They talk about the fact there might be a slightly different adverse event profile because of lack of effects on IL-2 and IL-15 and what that might do to regulatory T cells and natural killer cells, for example. But of course, that's all hypothesis until you do the trials you see, and then it gets into larger use. So, I think it's always good to be a little bit cautious about these things. So they talk through the trials, they talk through some of the data. They mentioned deucravacitinib as the one that's sort of furthest along in development. And I think that's probably most of what's there. So a really good review, good authors, nice background to the subject of TYK2 inhibition.
Great, yeah. So I think it is shaping up to be a very interesting field, isn't it? Partly because the deucravacitinib data looked quite impressive to me, especially in the skin, but also because I think that a lot of us thought that the trials of drugs like baricitinib would be successful, and actually weren't, although not completely negative, as often in the case.
Yeah, so there's some positive bits in the baricitinib data, isn't there?
Yeah, exactly, especially in the joints. And the TYK2 data in the skin looks, but the TYK2 data for deucravacitinib in the skin looks quite good. And yeah, it's this increased specificity, isn't it, that you get with TYK2, that it really is type 1 interferon signaling and IL-12/23, and that's what
exactly, and less of the growth hormones, less of the hormones, and also the molecules that they're developing, the drugs that are binding slightly different, whether that will play out into making a big difference, but they're binding to slightly different bits of molecules than the other JAK inhibitors, which were against the ATP binding groove. So there are some differences here, and it just needs more data to know. It's early days to be wondering whether some of the concerns we have about side effects with the other JAK inhibitors will be different, because you need large populations and you often need specific studies to show that. But new set of drugs, slightly different, and a good biological hypothesis about why they might be effective.
And I often think I talk about this a lot, but we always think about lupus as targeting B cells because B cells are attacking healthy tissues. But lupus has a huge innate component, and that innate component is kind of driven by tissues themselves. And I think what's missing in our range of drugs somewhat is drugs that target that innate component. We've got lots and lots of ways to target B cells and T cells, and if that's not right for you, you'll get through a lot of drugs quite quickly without any success. And so anifrolumab was the first really, apart from hydroxychloroquine, was the first real drug that targets that innate immunity. But the TYK2 inhibitors, I think, will be the second. And so I think it'll be a very important part of the range of therapies, the different strategies we're able to use. And should we go on to the last one then?
Yep.
So this one is a study from Sweden by Yanis Parodis and Christopher Schervel, which is from the group at Linköping, which they do quite a lot of these cohort-based studies and epidemiological studies. And this is about trying to understand the relationship between lupus, low disease activity state, and organ damage related to patient quality of life. So we know that in lupus, health-related quality of life is quite poor despite our best efforts. And despite having, this is done in Sweden, a country that has access to good medical care and good therapies, but I think they still see that their patients will, despite that, will still complain that quality of life is quite poor. And the reasons for that can be quite complicated, because the obvious thing is disease activity causes poor quality of life. But as time goes on, living with lupus becomes more complicated. You have more things than just disease activity. You've got a lot of therapies, you've got damage, you've got the effect of living with a chronic disease for a long time, or what effect that has on your life. So this was a study where they took patients where they had a lot of long-term data in a lot of detail to look at the association between these variables. So LLDAS is the measure of disease activity, as we said earlier, low SLE diet, low steroids, damage, and health-related quality of life measured by EQ5D and other things like patient VAS for pain, fatigue, overall lupus-related health. They had 327 patients. They had average follow-up of 8.5 years. 90 of those patients were incident, as in followed from diagnosis, and 80 of those patients had moderate to severe disease. So those were two subgroups that they were interested in. Disease activity, as you might expect, generally declined over time from diagnosis. And also, as you might expect, damage increased. Well, it can only increase, can't it? They also noticed that there was a slight improvement in EQ5D initially, but then worse after about 5 years. So they found that disease activity was a predictor of health-related quality of life, so shown in the table there. So LLDAS, so they classified patients as those who had sustained LLDAS, meaning all of the visits over the previous 18 months in LLDAS, versus those who didn't have that. So having LLDAS and sustained LLDAS were both associated with better health-related quality of life. And damage was associated with worse health-related quality of life, as were steroid use. There was also some association between antidepressants and health-related quality of life. So as on the slide there, reducing disease activity, reducing the use of glucocorticoids, and preventing damage could have direct benefits for patients across multiple patient-reported outcomes. And I guess what does it mean to me? I suppose it's about the fact that to get patients to feel well, you have to think about more than just treating inflammation. There's more going on. What did you think about that one?
Yeah, it's also trying to collect information that supports treat to target, really, isn't it? It's saying if we can control people's disease activity, aim for a score, and then follow people over a sustained period of time. And that's what stands out with this paper, isn't it? Some people were looked after for and observed for quite a long period of time, much longer than most of these sorts of studies, that they are more likely to do well. So aiming for that low disease activity state, which, we know and we aim for it, but it's much harder to prove that in lupus than it is at the moment for rheumatoid or some of the other diseases that we look. So to me, this was an important bit of catch up to try and understand that, to try and reinforce the importance of aiming for something, treating something. And also reminds me, it's easy to forget all these scores, isn't it? As you've mentioned, that the things that are within this definition of low lupus disease activity state of the SLEDAI-2K being less than or equal to 4, no new items, the physician global less than or equal to 1, and the prednisolone less than 7.5. That having that in my mind was just reminded once again by reading through this.
The other thing I thought about, this paper sort of reminded me of something I'd been thinking about a bit in the clinic. So it was the approach they took was quite good, I thought, because it's this thing about phases of disease over time. They talk about like incident disease or longer standing disease. And I sort of talk about that quite a lot with patients, because when you're first diagnosed with lupus, kind of everything's about disease activity, isn't it? You have poor quality of life because you're full of inflammation. It's untreated. And in that phase, we kind of know what to do. We give therapy, we can reduce disease activity, and often the effects of that can be quite magical, and you feel a lot better. But as time goes on, that's when it gets less simple, isn't it? You've got damage issues, you've got all the drugs you're taking, and you've got also, like, you get all these, and again, they touched on this with the comment about the antidepressants affecting these equations, is that, you've got, like, life is, what has it done to your life? Like 10 years after you've had lupus, you're not having the life you thought you were going to have. Maybe some things in your career or your family aren't what they used to be. And obviously there's no drug in the, so at the start, it feels like you know what to do, you treat it, and we've got the tools to make people feel better with medicines. But later on, it's not quite as easy as just pulling those levers.
But I think that's the key, though, isn't it? We know the disease, the drivers of the disease activity at the beginning. We know the biological processes. We have drugs that will treat that. But all those other more complicated things, there aren't necessarily therapeutic interventions. And maybe this speaks to the importance of a program of care which is much wider than just the drugs we use, and how we can support people to exercise, best diet, give up smoke, all those other things that, even that, I don't think will solve all of it.
No,
but it will
that's
all,
right.
it will all help a bit.
I've said this to people in the clinic. I've said there's no drug in the world that will give you the last 10 years back. And we have to. So that's part of the frustration, isn't it, of long-term lupus? Is that actually what used to seem like there used to be lots of easy options, they aren't really there anymore.
Yeah, absolutely right.
Yeah, great. So that's all we've got time for this week. So thanks for joining me, Chris. It's great to hear your thoughts always on the latest developments in lupus management.
Yeah, thanks very much, Ed.
And thank you, everyone, for listening. As always, you can find the full slide decks for each of these papers at lupus-forum.com, which is free to access, and all the content is free to download. So you can download the PowerPoints and use them in your own teaching or your journal clubs. And if you register for updates on the Lupus Forum, then you'll receive email updates when new content becomes available. And you can also find that by following us on Lupus Forum, or one word, on Twitter and on LinkedIn. So thanks again, and see you next time.